Hello and welcome. On behalf of CME Outfitters, I would like to welcome and thank you for joining us for the second episode in a series of 3 CMEO snacks titled Refining Treatment Targets for the Management of Psoriasis. The CMEO snack series is supported by an educational grant from Bristol Myers Squibb Company. I'm Dr. April Armstrong, Professor of Dermatology and Associate Dean for Clinical Research at the University of Southern California. I also direct our psoriasis program in the Department of Dermatology. Joining me today is Dr. Melinda Gooderham. Dr. Gooderham is the Medical Director at Skin Center for Dermatology and an Assistant Professor of Medicine at Queen's University. She's also Consultant Physician at Peterborough Regional Health Center in Ontario, Canada. Welcome, Melinda.
Thanks, April.
In addition to CME CE credit, today's activity is eligible for ABIM MOC points. Once you complete the activity, provide your ABIM ID and birth date when completing the evaluation. CME Outfitters will submit your MOC points. You can also claim this activity as a CME for MIPS improvement activity. In this 3-part series, we're excited to focus our presentation today on some of the new data presented recently at the AAD VMX. Our learning objective for this CMEO snack is to evaluate the role of TYK2 versus JAK1, JAK2, and JAK3 signaling pathways in psoriasis and their role as emerging therapeutic targets. Melinda, in order to understand treatment targets for new agents, we first have to understand the pathogenesis of psoriasis. Can you start us off?
Absolutely. Although the pathogenesis is complex, I think there's one thing we really understand well is the role of the interleukin-23 Th17 pathway, where interleukin-23 is the key regulatory cytokine and interleukin-17 is the key effector cytokine. And we have some very effective treatments, some monoclonal antibodies that target this axis. So, for example, targeting interleukin-23, we have ustekinumab, guselkumab, risankizumab, and tildrakizumab. And then targeting the effector cytokine, interleukin-17, we have secukinumab and ixekizumab targeting interleukin-17A, and then brodalumab targeting the interleukin-17 receptor. And although these medications are very effective for many patients, there are some limitations. So, number one, there is a cold chain requirement for delivery of the product to the patient. It does require an injection for administration. And because they're all large proteins, there is a risk of immunogenicity with these agents, and that can lead to potential adverse effects. So, for example, some patients have injection site reactions, which are intolerable and may require a switch in therapy. And also, there may be a loss of efficacy over time with some of our biologic agents. So, although they're very effective, there are some limitations. So, if we think of targeting these pathways, we can either use a monoclonal antibody to target the cytokine or its receptor outside the cell, or we can target the same pathway by using a small molecule and targeting that signal inside the cell. And so the sort of evolution of TYK2 and JAK inhibitors are targeting these signaling molecules on the cytoplasmic side of the membrane. So what we know about that key regulator cytokine, interleukin-23, is that it does signal through JAKs, and it signals through TYK2 and JAK2, which pair up on the cytoplasmic side of the membrane. And compared to some of the first generation JAK inhibitors, which were more what we call a pan-JAK inhibitor because it targeted multiple JAKs, some of the newer agents are a little more targeted or selective, where they don't have such a broad effect and they're more targeted. So if you see what I mean here by the number of type 1, type 2 cytokine receptors that rely on JAK signaling, you'll see that the JAKs and the TYKs pair up inside the cell to transmit the signal. So once the cytokine binds to its receptor, the JAKs then phosphorylate the STATs, which dimerize and move into the nucleus to lead to whatever effect whatever the message is that's being sent. Other than the disease pathway, there are other normal physiologic effects that happen through these signaling pathways, things like bone metabolism, lipid metabolism, hematopoiesis. These are all normal functions that also rely on JAK-STAT signaling. So when you have a more broad inhibition, you may have some of these off-target effects and target something like hematopoiesis, leading to neutropenia, thrombocytopenia, things like that. So the more selective that you can be, the more likely you are to reach your target without having off-target effects. So if we take another look at what cytokines do signal through these type 1, type 2 cytokine receptors, you can see JAK1, 2, and 3 dependent cytokines listed here, like interferon gamma, interleukin 2. And then we have the TYK2 dependent cytokines. So these are the cytokines that will rely on signaling through TYK2. And there we see some important cytokines in the pathophysiology of psoriasis. So we have interferon alpha, interleukin 12, interleukin 22, and interleukin 23. Whereas if you look at some other cytokines like TNF alpha and interleukin 17, even interleukin 36, these do not rely on the JAK-STAT signaling pathway to transmit the message. So it would make sense if you wanted to treat psoriasis, TYK2 seems like the most likely target because of the importance of that key regulatory cytokine signaling through that pathway. So I know, April, just talking about TYK2, you were the lead presenter on the Late Breaker this year at the AADVMX for deucravacitinib, the TYK2 inhibitor being investigated for psoriasis. So do you think that you could tell us a bit more about that study?
Yes, absolutely, Melinda. And thank you for that really great review of the mechanism of action with regards to the different JAK and TYK inhibitions. So for a very long time, I feel like for oral therapies, we had to oftentimes trade between efficacy and safety. And I do think that deucravacitinib is different. Deucravacitinib is unique in that it's a highly targeted molecule for TYK2. And it does this by really binding to the regulatory domain of TYK2 and thereby causing a conformational change in the protein. And this results in specific inhibition of TYK2. And as a result, this leads to also inhibition of type 1 interferons, as well as IL-23 mediated pathways. And as you will see, as our understanding of psoriasis has evolved, this mechanism of action of targeting TYK2 gives us an oral option that can be both efficacious and have a good safety profile. So let's take a look at 2 phase 3 studies with deucravacitinib, POETIC PSO1 and POETIC PSO2 studies. And these studies compare the efficacy and safety of deucravacitinib versus placebo and apremilast in patients with moderate to severe plaque psoriasis. And patients with moderate to severe plaque psoriasis were randomized 2:1 to deucravacitinib 6 milligrams once daily, placebo or apremilast 30 milligrams twice daily. And in these 2 studies, the co-primary endpoints were PASI 75 and SPGA 0 or 1, or clear or almost clear responses versus placebo at week 16. So what did the study results show? And here we see the results for PASI 75 at week 16 and week 24. And on the left-hand panels for week 16 results, we see that deucravacitinib, which is in dark blue, demonstrated superiority versus placebo, which is in gray, at week 16 for PASI 75. And specifically at week 16, in PSO1, about 59% of the patients on deucravacitinib achieved PASI 75 compared to 12.7% in the placebo group and 35% in the apremilast group. And the results were similar in PSO2. And on the right-hand panels, we see that deucravacitinib responses increased beyond week 16 and were also superior to apremilast, which is in purple, at week 24 for PASI 75. Now, let's look at another endpoint. And importantly, among patients who achieved PASI 75 responses at week 24 with deucravacitinib, how do they do long-term with regards to deucravacitinib beyond that. And what the study showed is that with continual treatment with deucravacitinib, this resulted in the maintenance of PASI 75 response through week 52, over 80% of the patients maintaining PASI 75 through week 52. Now, I mentioned earlier that the study looked at two co-primary endpoints, one being PASI 75 and the other one being SPGA 0 or 1, or physician global assessment of clear or almost clear. So let's take a look at SPGA 0 or 1 results. And overall, what we see is that similar findings were seen with SPGA 0 or 1, clear or almost clear, as was observed with PASI 75 in terms of the trends. So at week 16, which are the left-hand panels, deucravacitinib, again in dark blue, demonstrated superiority versus placebo, which is in gray at week 16 for clear or almost clear endpoint. And specifically in PSO1, 54% of the patients achieved clear or almost clear compared to 7% in the placebo group and 32% in the Premalas group. And similar results were shown with the PSO2 study. On the two right-hand panels, we see that deucravacitinib response increased beyond week 16 into week 24 and were shown to be superior to apremilast at week 24 for the achievement of clear or almost clear. Now, let's also take a look at the integrated safety data for these two studies up to week 16. And what we learned is that the total number of AEs and SAEs were similar across the groups. And adverse events leading to discontinuation were numerically lower with deucravacitinib versus placebo and apremilast. Importantly, nasopharyngitis and upper respiratory tract infections were the most common AEs in the deucravacitinib group, and diarrhea, headache, and nausea were the most common AEs in the apremilast group. Very importantly, no clinically meaningful changes were observed in total cholesterol, creatinine, phosphokinase, neutrophils, or platelets with deucravacitinib over 16 weeks. And similar results were also obtained over 52 weeks for these additional laboratory parameters. Now, these are important because when we think about TYK2 inhibition, it's important to see if there were perturbations in the laboratory parameters, and we did not see this with regards to the deucravacitinib studies, the phase 3 studies. So, Melinda, I think this has been a great discussion, and I wanted to summarize our discussion with our SMART goals, which are specific, measurable, attainable, relevant, and timely. And we hope that our audience will take away from this particular presentation and can apply to your practice in the future. And the SMART goals, I would say, for our session is number one, to understand the pathogenesis of psoriasis. And you have certainly offered great insights into that. And also we talked today about the efficacy and safety of the emerging agents, and hopefully we can add that to our armamentarium of therapies for our psoriasis patients. Another SMART goal is that we now understand not paint all the JAK inhibitors with the same broad stroke. And it's important to appreciate the differences in terms of mechanism of action, as well as what some of the new inhibitors against TYK2 can offer for our psoriasis patients. For audience, please check out part 1 and 3 of the CME Snack series available on the website by visiting the Dermatology Education Hub at www.cmeoutfitters.com. Don't forget to complete the evaluation and collect your credit for today's program. You'll be able to print your certificate from the platform. Again, I want to thank you, Melinda, for your contributions to our discussion today, and also to our audience for joining me today. I hope the presentation gave you a good foundation about the different treatment targets that are informing our development of new therapies for our patients with psoriasis. Thank you.